Derek Hausenloy from London and Singapore. It's great to have you here, and you're going to be telling us about reducing myocardial infarct size, translational challenges, and opportunities.
Great. Thank you, Chairman, ladies and gentlemen. I'd like to thank Naveen and Noam and the ACURE working group for inviting me here. I'm not going to be talking specifically about unloading, but about reducing myocardial infarct size, translational challenges and opportunities. And it's great to hear that acute unloading in STEMI patients may be a new future strategy for reducing infarct size. So I think we would all agree there's still a need to reduce MI size and improve clinical outcomes in our patients. This data is from the CIRCUS study, which has been mentioned in this meeting, where anterior STEMI still had a 7% death and 22% heart failure rate at 1 year. So there's still a need for interventions to either target reperfusion injury or target ongoing ischemia reperfusion injury for patient benefit so we can reduce infarct size and prevent heart failure. And we and others are very interested in giving new treatments or investigating new therapies that can be administered at the time or prior to reperfusion to reduce infarct size. So as we all know, there have been many neutral clinical trials investigating therapies for reducing MI size, and we can discuss, or we can have a whole conference trying to discuss this. But I'm just going to list some of the factors that should be considered that can help inform maybe future design of MI trials. So we all know the clinical setting of STEMI and primary PCI may be quite challenging itself. We've heard some people and some commentators question the existence of myocardial reperfusion injury. But I think us and others would agree that both in the experimental and the clinical setting, reperfusion injury does exist and is important, but I don't think we've found a way to target it effectively to improve clinical outcomes. In patients presenting with a STEMI, co-medication could impact. We've heard from Michael Cohen today that P2Y12 inhibitors may impact on the new treatments we're investigating. In the recent NOMI trial, which showed that inhaled nitric oxide did not improve clinical outcomes, a post-hoc subgroup analysis showed that those patients that had GTN prior to primary PCI did not benefit when inhaled nitric oxide was given. And of course, all our patients receive morphine. This itself can condition. So even the clinical setting of STEMI represents a challenging scenario or setting for looking at our new therapies for reducing infarct size. Now, the choice of therapy is important. Too many studies will just do inadequate testing of a therapy in the preclinical setting and then move straight to the clinic. Even the animal models we use juvenile animals with no disease, with no comorbidities, no co-medication. And once we see a drug is effective in a small animal clinical setting, we often or not will go into a clinical trial, a proof of concept study, which turns out to be positive, and then we move to an outcome study. So we really need to improve the preclinical testing of therapies. And this applies to the unloading, which we've heard about today. I think we've heard, and it's great that in a single large animal study it's effective, but I think we'll need multicenter study testing just to ensure it's a robust therapy before moving into the clinic. Now, we talk about inadequate testing. I've just put 2 or 3 trials here, the CIRCUS trial, the nitrite trial, and the TRO 40304 trial. And all of these, you could say, were not inadequately tested in the preclinical setting, or in fact, the preclinical data was mixed. In particular, the nitrite study, so the NIAMI trial and the nitrite MI trial, the preclinical data suggested that nitrites could reduce infarct size when given at reperfusion in animal models. But in the NHLBI CSER network, which was a multicenter network of small and large clinical animal models, it was found that a nitrite was not effective and did not reduce MI size. So it could explain why the 2 clinical trials were neutral. So I think it's important that we take forward any clinical trial those therapies which show robust and consistent cardioprotection before we test them in proof of concept clinical studies. Then there's patient selection. I think this issue has come up in this meeting. Do you take all comer STEMI patients or do you select a group? If you select a specific group which you think is more likely to benefit from an intervention, then obviously you impact on feasibility of your study. Now, most of the cardioprotection studies suggest that those patients with short ischemic times, less than 4 hours, anterior large MIs, TIMI 0 pre-PPCI flow, so completely occluded arteries, and no obvious collaterals are the ones that are most likely to benefit from a cardioprotective therapy. But of course, by the time you select that group, that's probably 20 or 30% of your eligible STEMI patients. So that impacts on the feasibility of doing the study. Comorbidities, we've heard that comorbidities in the experimental setting can impact on the cardioprotective efficacy of different therapies. But in a clinical setting, does it really matter? Obviously, all our STEMI patients have multiple comorbidities, including age, diabetes, hypertension, and all of these in experimental models have shown to impact on the efficacy of interventions. Whether they can impact in the clinical setting is not clear, but post-hoc analyses of trials of remote ischemic conditioning and post-conditioning, interestingly, have shown that despite the presence of diabetes or hypertension, there seems to be benefits. So maybe in the clinical setting we're lucky in that the interventions we're looking at can overcome any increased threshold of protection with comorbidities. Study design is important. Most of our focus and others is to target the reperfusion injury which occurs in the first few minutes of reperfusion. And so you need to try and get your intervention on before you open up the artery, before the primary PCI, and that can be challenging in itself. We've heard that the hypothermia clinical trials were neutral. If you look at the experimental data, it is clear that hypothermia is very strongly cardioprotective, but the intervention has to be on board prior to ischemia or during ischemia. And the preclinical studies suggest it doesn't work at reperfusion. So it may in part explain why the neutral hypothermia studies were undertaken. When we move to a clinic, we would just usually try one dose of an intervention, and so we lack proper phase 2 testing or dose responses. So this can apply to a number of clinical trials, the CIRCUS study, the PROTECT AMI trial, an early BAMI trial, and a DYNAMI 3. Just talking about the early BAMI, this was IV metoprolol given at the onset, at arrival at the hospital, and they used a dose which was half the dose given in the original positive study, and also they didn't give the intervention as early as the previous Medicare study. The DYNAMI 3 trial, which was presented at the ACC, was a large post-conditioning study which showed neutral effect on clinical outcomes, and they too used a different intervention to those that had been shown in the proof of concept studies. So it's important that the dose of the therapy and the timing of the therapy is taken into account in study design. Then, of course, there's an important issue about study endpoints. And it was interesting to hear the talk about this recent meta-analysis showing that infarct size could be a surrogate or even primary endpoint for clinical studies. We should discuss maybe MI size versus myocardial salvage. We know myocardial salvage is more sensitive and can allow you to use less patients, but myocardial salvage requires you to be able to measure the area at risk, and nuclear medicine is the current gold standard. We know that MRI has the potential to measure the area at risk by measuring edema, but that's controversial, and we can discuss that later. As for hard endpoints, we know that those most relevant to cardioprotection are most likely to be cardiac death and hospitalization for heart failure. And as we know, at least in cardiac death, this event rate is in decline, although the heart failure rate is increasing. So this has an impact on clinical outcome studies. And as you know, the recent CIRCUS study, which was neutral, and the DYNAMI 3 trial, that affected the design of their primary endpoint, with CIRCUS having to introduce an LV adverse remodeling LV size in their primary endpoint, and DYNAMI 3 having to follow their patients for 3 to 5 years to get the event rate they needed. So talking about future opportunities for reducing MI size. So these are studies which are ongoing of interventions which have the potential to reduce MI size and improve clinical outcomes. Exenatide, as you know, is a GLP-1 agonist that's given as a diabetic therapy that has been shown to reduce MI size. So far, there's been 2 positive proof of concept studies. At this moment in time, no neutral studies. The metoprolol I mentioned, so IV metoprolol in the ambulance, was shown to reduce infarct size and prevent heart failure in the Medicard Scenic trial. Unfortunately, the early BAMI trial was neutral, but there are multiple potential reasons for this, including the dose and the timing of the therapy. I know there's a clinical outcome study planned for IV metoprolol, which Borja Ibanez is going to be looking for funding to do, which is called the MOVE-ON trial, to see if IV metoprolol can improve clinical outcomes. We've heard a couple of times about remote ischemic conditioning. For those of you who are not aware of this, this is a blood pressure cuff on the arm to stimulate protection in the heart and other organs. There have so far been 6 or 7 positive proof of concept studies, including one by ourselves, and I'll just show you the results of that. And there's a large clinical outcome study ongoing now. And then, of course, there are new approaches for reducing MI size, newer interventions such as unloading, which we've heard at this meeting, but also I think we need to target other components of the heart, not just the cardiomyocyte, such as the microvasculature. We should target inflammation, and it's a very interesting abstract here. We should target the inflammasome. So I think we need to look beyond the cardiomyocyte, or we need to protect not just the cardiomyocyte, but the microvasculature and inflammation simultaneously, or by giving combination therapy. The recent Lipsia trial published by Eitel in Germany showed that combining remote ischemic conditioning and post-conditioning was a more effective way of reducing infarct size than the individual interventions alone. And the planned combat MI trial will test remote ischemic conditioning and exenatide in a factorial design to see if we can get additive effects with two different treatments. I'm just going to finish off by mentioning about remote ischemic conditioning. This was the proof of concept study in which we showed that applying 4 cycles of ischemia, brief ischemia to the arm with a blood pressure cuff and arrival at the hospital prior to primary PCI, we could reduce infarct size as measured by MRI as a percentage of the left ventricle. And we managed to reduce it from about 22% of the LV to 19% of the LV. So this is an absolute reduction of 5 percentage points. And it's interesting talking about this meta-analysis which showed that a 1% absolute reduction in infarct size could potentially correlate with less hospitalization for heart failure. Now, of course, we need to undertake the prospective study to actually investigate whether remote ischemic conditioning can improve the clinical outcomes. This is just showing the use of cardiac MRI to measure infarct size and salvage. But this is the large multicenter study which we're undertaking in the UK and also in collaboration with Hans-Erik Botke in Denmark, where we're looking at 4,300 patients in total. 2,000 patients will be recruited in the UK, and the rest will be recruited in Denmark. And we're randomizing patients to receive the remote ischemic condition on the arm prior to primary PCI, and the primary outcome is cardiac death and hospitalization for heart failure at 12 months. In the UK, we've recruited 800 patients out of the 2,000 so far, and we only started in January. And in Denmark, they've recruited 1,500 patients out of the 2,300 patients. So hopefully in a year or two's time, we'll know whether the simple, non-invasive intervention of remote ischemic conditioning can actually improve hard endpoints such as cardiac death and hospitalization for heart failure. This is a new study which we're about to start in Singapore, and this sort of follows on from the data we heard from Michael Cohen. We all know that oral P2Y12 inhibitors do not offer maximum platelet inhibition at the time of primary PCI in STEMI patients, whereas Cangrelor, an IV platelet inhibitor, given prior to PPCI, within 2 minutes can offer maximal platelet inhibition. So in this particular study, we're going to be giving IV Cangrelor specifically prior to primary PCI to see its effects on reducing microvascular obstruction and reducing MI size in STEMI patients. It'll be a 210 STEMI patient study undergoing primary PCI, and patients will be randomized to receive IV Cangrelor initiated prior to primary PCI or saline placebo, and our primary outcome will be myocardial infarct size on CMR at 6 months. So we're hoping that the dual effect of Cangrelor in inhibiting platelet and having a direct cardioprotective effect may show some benefit in this study. So in conclusion, there are a number of factors contributing to the translational challenges reducing MI size, and we need to optimize trial design, and we need to find new therapies and targets. The current therapies that are under investigation are exenatide, metoprolol, and RIC, and future therapies such as unloading and newer targets outside the cardiomyocyte, and new strategies such as combination therapy are needed to see if we can reduce MI size and improve outcomes for our patients with STEMI. Thank you.
Derek, that was wonderful. A couple questions. Remote ischemic conditioning, the literature's mixed on using it after coronary bypass, so I wonder if you could just briefly comment on, does it work or not? Is it related to anesthetic? And secondly, people are thinking about using it for prevention of radiocontrast nephropathy, so I'm just wondering if you could comment on those two potential applications.
Yeah, so remote ischemic conditioning has been tested by us and others in the CABG setting, in the ERICA trial and the RIP Heart trial, two very large multicenter studies. Unfortunately, did not show any benefit in improving clinical outcomes. And I think there's multiple reasons for this, and anesthetics, choice of anesthetic agent could be a factor. It has been suggested that maybe it's the propofol that interfered with the protection. It could be the clinical setting itself. As you know, there's not so much ischemia reperfusion injury happening in patients undergoing CABG surgery because they're well protected by cardioplegia and hypothermia. And so there are multiple factors. But I think the STEMI setting, in which there's much more ischemia reperfusion injury, that there's much more of a target for RIC to reduce. So I think it may be more effective. RIC, in a couple of studies, have been shown to protect against contrast-induced nephropathy in patients undergoing angiogram or PCI. And the actual mechanism for this are not clear, but I think further confirmatory studies are needed before one can say you should do this prior to all angiography. But I think with RIC, it's an interesting intervention because it's harmless, it's easy to apply, and there's been no adverse effects ascribed to it so far. There's a couple of problems with the RIC. One is we don't know the actual mechanism through which it works, and two, no one's really standardized the protocol which is most effective. And so I think there are some issues with using RIC, but given that it's so non-invasive, very easy to apply, it's no wonder there's so many trials looking at this.
If you wanted to do it, do you maximize or do you improve benefit by having the patient exercise while the blood pressure cuff is elevated? I mean, squeeze their arm?
I mean, you could do that. To try and increase the ischemic times, no one's looked at that. But I think 5 minutes of cuff inflation has been shown to at least be effective. The number of cycles, which is most effective, hasn't really been tested. The other dimension for the RIC is that you can do daily therapy. So you can do daily application of RIC, and studies are ongoing to see if this is effective in preventing adverse remodeling post-MI.
Derek, this is going to be completely hypothesis, of course, but do you think that RIC in combination with mechanical unloading, as was discussed earlier by Naveen and others, can actually be the time to do the RIC?
I think that's a great point, and we hinted to this with the combination therapy. I mean, if the unloading, its primary effect is to sort of reduce myocardial oxygen consumption, whereas RIC is activating or pro-survival kinases, then you could imagine there could be a synergy between the two interventions.
Terrific. Thank you, Derek. So we're going to